And how will we identify this fracture? One is pain, loss of function, deformity, shortening, crepitus, swelling, discoloration. How will you diagnose? It will be diagnosed by the history, physical examination, X-ray, CT, MRI. How will you manage? Basically, any fracture, first we have to treat the basic systemic stabilization of the patient by checking the airway, breathing, circulation, and then stabilize the limb with the immobilization with the with the traction followed by splinting, and then followed by identify the type of the fracture. Then we can deal to to deal to deal with the any external fixation or internal fixation with the nailing or plating or screws. So after fixation, what are the complications of the fracture? The main complications of the fractures are coming to introduction. I already explained about these all things. Fracture is a break in the current of the bone, partial or complete. There are several complications of the fracture. Depending upon the complications, for the easy understanding, it is divided into immediate, early, and late. Or they also classified as local causes or systemic causes. Comes to immediate. Immediately occurs at the time of the injury. Either it may be systemic, that is maybe hypovolemic shock. Local, it may be vascular injury causing hemorrhage, damage to the such as brain, lung, liver, spleen, and bladder, damage to the muscles and nerves, joints, nerves, and surrounding tissues. And coming to early, occurs initial few days after the injury. It is divided into systemic and local. Systemic, it is hypovolemic shock, acute respiratory distress syndrome, pneumonia, fat embolism syndrome, DVT, and pulmonary embolism, and tetanus, gas gangrene, traumatic fever, septicemia in open fractures. And local, it is infection, compartment syndrome, hematorosis in intra-articular fractures, and setting which leading to the mycal- myositis ossificans. And late complications are abnormalities in the union, delayed union, non-union, malunion, cross union, and avascular necrosis, reflux sympathetic dystrophy, vulcanic ischemic contracture, myositis ossificans, osteomyelitis, shortening, joint stiffness, osteoarthritis, rupture of the tendon, and growth disturbances if it is pediatric cases. And coming to first important complication of the fracture is nothing but hypovolemic shock. Hypovolemic shock, it is also called as hemorrhagic shock. The shock, first of all, what is meant by shock? Shock is defined as inadequate perfusion and oxygenation of tissues due to failure of circular system which led to hypoxia, which may damage to the vital organs. Blood flow to the tissues is reduced, so resulting in the is reduced. So as a result, minimum requirement for oxidative metabolic occurs in the fracture of the long bone, pelvic bones, and multi-system injuries following RTA, burn, surgery, and severe dehydration. Commonest cause of death is the following fracture. And coming to what are the source of hemorrhage? Hemorrhage is external in compound injuries of pelvic injuries, internal in the blunt injuries of abdomen, chest, and pelvic injuries. And blood loss is female short fractures which causes 500 to 2000 ml, and pelvic fracture is 1000 to 2500 ml, and tibial short fracture is 500 to 1500 ml. And coming to clinical features is hypotension, tachycardia, oliguria, and alert sensorium, cool, calming, moist sins, increased respiratory rate, low volume, rapid thready pulse, sweating, shrunken eyeballs. These are the symptoms sim- as of the dehydration. Same, sweating, shrunken eyeballs, tongue, play, and dry. Patient gradually become drowsy, BP falls, and retinal outlet decreases, and patient may become unconscious and might die. These are the estimated fluid and blood loss based on the patient initial presentation. This is a typical representation or class 1, class 2, class 3, class 4. And the following parameters are blood loss in ml, blood loss in percentage, pulse rate, blood pressure, respiratory rate, urinary output, CNS, and mental status, and fluid replacement. And class 1 up to 750 ml, class 2 750 to 1500 ml, class 3 it is 1500 to 2000 ml, class 4 it is greater than 2000 ml, and blood loss is up to 15%, and class 2 is 50 to 30%, and class 3 is 30 to 40%, and class 4 is greater than 40%, and pulse rate is less than 100 and greater than 100, greater than 120, and greater than 140, and blood pressure is normal in class 1, class 2, and decreased in class 3, and decreased in class 4, and pulse pressure is normal or increased, decrease or decrease in the remaining classes. And respiratory rate is 14 to 20, and 14 to 30, 30 to 40, and greater than 35 is class 2, and urine output is greater than 30 ml per hour is class 1, 20 to 30 ml is class 2, 15 ml in class 3, and negligible. And CNS mental is slightly anxious, mildly anxious and confused and lethargic. And fluid requirement is crystallite in class 1, class 2 it is crystallite, and class 3 crystallites and blood products. How will you manage? General principle, the goal to maintain the arterial pressure and to ensure the adequate perfusion and oxygen delivery to the vital organs. And emergency management is head low position respiratory support, initial fluid resuscitation, crystal the fluid of choice except in head injury cases, blood transfusion therapy, Hematocele can be used if blood not available. Urine output measurement 24 hours. Urine output should be maintained with the fluid input output charts, and renal fluid should be assessed. And drugs, analgesic, antibiotic, corticosteroids can be given. And active bleeding should be identified in the thorax, abdomen, pelvic. Continued bleeding may lead to surgical intervention. Management of fractures, limb, wound debridement, and immobilization. After stabilization of the patient, ECG monitoring should be done by rhythm disturbances, arterial line for measurement of arterial pressure, and pulse oximeter for the fluctuation in the arterial oxygenation. Frequent measurement of the arterial blood gases, serum electrolyte, and complete blood count should be done. End point of resuscitation, serum lactate less than 4 millimole per no base excess, vital within normal limit. And this is the pictorial representation where we are putting the immobilization with the plaster of Paris, or for open fractures we are giving external fixator. And these are the most common injury of the blood vessel during the, depending upon the pattern of the fracture and the site where it is occurring, the surrounding blood vessel will be injured. And coming to femoral artery is mainly involved in fracture of the lower third femur, and popliteal artery is involved in supracondylar fracture femur, and posterior tibia is mainly involved in the dislocation of the knee. Subclavicular is fracture clavicle, and the brachial is supracondylar humerus fracture. Increases swelling. What is the clinical features? Is increases swelling, massive external bleeding. Long-standing cases may be paresthesia and paralysis because of the compression of the nerve, and neurovascular stitches. And signs of pulsations, paler, low limb saturation. If ischemia is prolonged, limb will be cold, clammy, and cyanosed. And diagnosis. If vascular injury is suspected, Doppler study is done immediately. Most relevant angiography can be done if available. Treatment is the main aim to arresting the bleeding by direct pressure or restoring the blood volume. All bandages and sprays should be removed. Fracture or dislocation reduced should be done as early as possible in circulation ratio. If after reduction no improvement to the circulation, wait for the maximum 1 hour to reassess. If pulse is still absent, vessel exploration is done. The torn vessel can suture or segment may be replaced by the vein graft. If vessel thrombosed, endarterectomy can be done. If vessel repair undertaken, stable internal fixation, impermeable anticoagulant like heparin used to irrigate the vessel. And delayed complication, contractures, and gangrene. Injury to the nerves, which is also most common thing associated with the fractures. These are the what are the major and neuropraxia. What are the stages of nerve injury? One is neuropraxia, axomatosis, neuromatosis, and nerve injury is dislocate in the what are the most common presentations where the injuries will be most commonly involved. If the patient presented with a dislocation of the shoulder, then axial nerve will be involved. Fracture of the shaft of humerus, then radial nerve is involved. Supracondylar fracture, then ulnar medial nerve is involved. Montigial fracture, then the posterior tragus nerve is involved. And dislocation of the hip, then is sciatic nerve involved. Commoperoneal nerve, then it is fracture neck of the fibula. Fracture neck of the fibula. These are the most common things. Diagrammatic representation showing the radial nerve, which is in the mid shaft of the humerus, and posterior dislocation causes sciatic nerve, which causes commoperoneal nerve, which causes foot drop. How will you manage? Mainly by conservative splintering of the limb, passive movement of the loin to prevent contractures, physiotherapy by exercise and stimulation. Operative management is if fracture need open reduction, nerve should be explored carefully. Open fractures with pneumothorax and need surgery. Primary repair done with 6 to 8 hours after injury if wound cleans. Delayed primary repair between 7 to 21 hours. Secondary repair 21 days after injury in case of late presentation or failure of conservative management. Or an injury to the viscera, fracture around the trunk can be complicated by injuries to the adjacent vagina. Rupture of the urethra bladder, perforation of the rectal wall in the pelvic fracture, penetration of the lung with life-threatening pneumothorax, fractures, injury to the kidney, splenic injury may follow local compression or crushing in abdominal trauma. Such injuries need early and accurate diagnosis, prompt and proper management as they are life-threatening. Another complication, first complication is hypovolemic shock. Another complication is compartment syndrome. Compartment syndrome is very commonly seen in the lower limb, particularly in the proximal part of the tibia, and the upper limb most commonly in the forearm. And mainly, what are the causes of the compartment syndrome? Is high energy trauma, crush injuries, injury caused by the falling objects, patient unconscious compression of the own limb, and swelling of the limb inside the or over the tight cast.